Welcome everyone to today's webinar. I'm Megan Wood with Becker's Healthcare. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. As president of Alton Memorial Hospital, David Brosh directs the operation of a 206-bed full-service acute care hospital that serves patients in a 5-county area. In addition to the hospital, Dave has responsibility for the affiliated 62-bed long-term care facility, Eunice Smith Home, located on the Alton Memorial campus. Dave has played an instrumental role in Alton Memorial's growth and was named the hospital's president in 2007. He served as Assistant Administrator of Support Services from 1998 until he was promoted to Vice President of Professional Services and Business Development in 2006. In these roles, he led development of the hospital's Cancer Care Center, expansion and renovation of the Health and Vascular Center, and implementation of the Human Motion Institute. Alton Memorial Hospital continues to be recognized as a leader in improved clinical quality, patient safety, and patient experience. Susan Samet is the Cardinal Health On-Site Clinical Director supporting BJC Healthcare. Her main areas of focus are identifying clinical initiative opportunities for process improvement or cost containment and helping develop strategies to successfully implement those initiatives. During her career with Cardinal Health, Susan served as a clinical manager or system clinical manager at 4 health systems. Susan has also worked with various outpatient clinics, including an anesthesia-based pain management and anemia management clinic, and as a manager of a 400-patient anticoagulation clinic. She also served as the pharmacy clinical educator within a clinical education department to develop a system-wide competency program. Kathy Chase is the product leader for the drug cost control services of Cardinal Health Innovative Delivery Solutions. Since joining Cardinal Health in 2003, Kathy has served as a senior consultant, project manager, solution lead, and services director. As product leader for Drug Cost Control Solutions, Kathy oversees the development and enhancements of the Drug Cost Opportunity Analytics software, clinical consulting services, GPO contract optimization services, and patient assistance program, eRecovery. Prior to joining Cardinal Health, Kathy worked in health system pharmacies as a pharmacy director and clinical leader. She has more than 30 years of experience in hospital pharmacies. Kathy, with that, I'll now turn the floor over to you.
Thank you. Today, what we're going to do is to discuss our continuous approach for managing supply costs as they play a crucial role in achieving savings. In addition, we'll identify some best practices to leverage the data and benchmarking to achieve the savings goals. Today, we're going to talk about why we took action, what our challenges were, the approach we took, review some success stories, talk about how to use data to drive the change, and provide you some final thoughts. Dave, I'll let you take it from here.
Okay, thank you, Kathy. So I guess it's my job today to really talk a little bit about Alton Memorial Hospital and the journey that I think we've been on for a while, and in and around our pharmaceutical services. But to kind of set the stage, really just wanted to give you a little bit about us here. We're part of a larger healthcare system out of St. Louis, Missouri, BJC Healthcare. We're a little unique in the fact that we're situated on the Illinois side of the mighty Mississippi, so to speak. And then recently, 2 other hospitals south of us in Illinois joined BJC Healthcare within the last couple of years. But so most of the hospitals within BJC are on the Missouri side, in and around St. Louis, have 1 hospital in mid-Missouri, Boone County. Also just wanted to mention real quick that for about the last 5 years, we've also been part of a larger integrated system called the BJC Collaborative, and that includes some major health systems across the state of Missouri as far west as Kansas City, St. Luke's, and into Illinois, central Illinois, Springfield Memorial, and down as far south as southern Illinois and Carbondale. So covering a lot of central Illinois, southern Illinois, and most of Missouri. We do a lot of work through the collaborative around some of the things we'll talk about today, and really expanding sort of our ability to learn from each other around what we're doing around pharmacy, but other types of quality, patient safety, and patient experience initiatives, and really has, I think, helped us succeed as we kind of trade ideas across the collaborative. A little bit more about Alton Memorial. As mentioned, we are actually 209 beds licensed, but we really staff around 160 on a good day. We have a pretty busy ER, around 40,000 ER visits, and then generally med-surg. But I think as we go through some of the success stories we've had today, it's important to note that we do have an oncology and specialty drug infusion center located on our campus. And I think, that's one area that we're primarily focused around some of our high-cost pharmaceuticals. Also, in my bio, it wasn't mentioned that I am a pharmacist by trade. Before my appointment here at Alton Memorial as president in 2007, really focused a lot around pharmacy and actually held some director positions across BJC in the past. And then more recently, was charged with some additional pharmacy responsibilities, started going forward as I'm now senior executive for the pharmacy services across BJC. And so we're really standing up sort of a new structure, which, I think will evolve over time. So to kind of get back to why we're here today, I think as the Affordable Care Act was passed in 2010, we really saw that, we were going to have to focus on the cost structure of our organizations, as reimbursement obviously was going to decline over time with a lot of the pieces that were set forth in the legislation. Medicare, Medicaid reimbursements going down. On top of that, we did have, as part of that, we did have Medicaid expansion in Illinois, which obviously was a federal reimbursement that came through the state. But the other piece that put some pressure on us was the fact that if you've kind of watched the news about Illinois and some of the issues that we've had here recently, we were without a state budget for 2 years. During that 2-year time frame, Medicaid payments were extremely slow, and on top of that, all of the group health plan, which all the state workers and retirees were part of, in a sense, was not funded. And so we went for about 2.5 years without receiving any dollars taking care of those state workers, et cetera. And so put an extra pinch on us, and we really had to focus on, again, our cost structure and how we were providing services for our patients. Obviously, continue to see reform and uncertainty around where we're headed for the future with healthcare and how that gets paid for. So, I think there's even more pressure today than we've probably seen back from about 2011 up to, call it 2016, 17. And so, the charge remains the same. We got to continue to reduce our costs to remain competitive and be sustainable for the future. And one of the areas, there's obviously a couple areas you always focus on, and that's your labor, and then your supplies, purchase services, and obviously we want to focus mainly on the supply purchase service component. And that's where we thought we had some opportunity, particularly in pharmacy. We've always looked at, obviously, some of the more traditional type ways to reduce our pharmaceutical expense through negotiating pricing contracts, generic therapeutic substitutions, even like IV to PO conversions and things like that. But we knew we had to do something different. We had to get more innovative in how we really focused on changing the way we use drugs and to reduce the overall cost of care. And we put a lot of heads together, not only here at Alton, but across BJC. We did stand up a system P&T probably about 5 years ago by now, and that certainly, has come a long way in how we look at our pharmaceutical expense and our formulary management over the course of that time. And it'd be kind of interesting, I think, to maybe compare and contrast, maybe down the road here in the discussion during the Q&A period, to hear what some others are, where they are along sort of this journey as we really try to be more collaborative and work together around formulary management and compliance. So as we kind of looked around, we said, you know, what other pathways might we walk down to achieve our targets? And really started looking around and using Cardinal as sort of a partner to identify areas that we thought we might be able to make a difference. And I will tell you, I think, you know, as we began this journey, kind of listing three what I think are key areas of focus. And the first one is really leveraging relationships. And I think that's the relationships that, you know, kind of already exist. You know, the folks, particularly the folks in pharmacy who have built great relationships with the physicians on our staff. You know, they've achieved a lot in the past. And I think it's capitalizing on those relationships and then reaching out from there to really garner additional support amongst their physician colleagues for what we're trying to achieve. Data, I think, number two, that's where Cardinal really came in to help us, I believe, is really, you know, getting your hands on as much data and benchmarking information that you can, because that is, in my mind, you know, one of the most useful and persuasive tools as we kind of sit down with our medical staff and look at these opportunities that we believe, you know, we had a chance to make a difference on. And then last but not least, really monitoring your success. You know, we had to really determine what metrics we wanted to monitor and then kind of set our overall targets. So it took some time, but, you know, we've seen over $2 million worth of savings over this period of 6 years that we've really been walking down this road. So kind of to get a little more detail around each of those key areas of focus, the building relation piece, you know, I think, you know, you're looking for people who already, you know, are in your corner, identifying those champions, those people who have traditionally been early adopters, and then taking those folks, sitting down with them with the data, the information, you know, that was given to us, and then leveraging the committees that we already have. This isn't something new. We didn't go out and set up, you know, a whole bunch of meetings and bring in a whole bunch of different people. We really tapped on the folks and the committees that we had and the structure we had in place already, because obviously everybody has busy days, and trying to add on what we're trying to do already in our normal activities was not going to fly. Utilizing the data, really, you know, then benchmarking we could use as a guidepost to really determine sort of where do we go from here. And then essentially, I mean, in many cases it was trying things, you know, in fact, TriStorm as they kind of call it, but, you know, piloting opportunities, working with particular disciplines to roll out these, you know, various venues of, you know, it might be in therapeutic classes, it might be in a particular service line, use a lot of rapid cycle testing, try it. If it doesn't work, take a step back and try something else. Here's where, you know, if you're failing, there's obviously some lessons learned, and you, again, try again. So, you know, there's lots of stumbling blocks. There's lots of people probably to pull in, whether it's local experts. Here's where we use some of our experts from Cardinal. We also use some of our experts in the system, where we identified a particular group or physicians who we felt could help us, you know, in discussions with our local medical staff. So, you know, at the end of the day, it's all about your success and the results. So I think, you know, acknowledging those successes, sharing them, not only here amongst our team members, the medical staff, obviously through the governance structure, through the department chair, moving that up into our Med Exec Committee goes a long way. I think if you see the results, they see the success, you know, it's kind of like a me too. Well, what can we do to help? And then celebrate, because I think it goes a long way to really recognizing the folks that have been at the front line and sometimes taken the hits to get to the end of the day where you've achieved the results that you're wanting to achieve. And then with the success that I think we had, it was an opportunity to share that with our colleagues across the enterprise, and a lot of the other community hospitals latched on to what we did here. They may have taken it and tweaked it a bit for their own local environment, but you know, I think others seen success. They had a little competition, which never hurts anything, and we were able to learn from others. You know, you start beginning to trade ideas, and I think success breeds upon itself. So, you know, I think there's been a lot accomplished, a lot of people involved, and I really see the future as, again, evolving more across BJC Healthcare as we kind of continue to learn from each other, using experts across the system to help where needed. You know, along the lines of System P&T, if we're making a decision around formulary, and then if somebody's having some difficulty in a particular specialty or therapeutic class or whatever that might be, you know, we can tap the clinical pharmacists at our academic center, can tap, you know, some of our physician colleagues across the system to really engage and help us. And we've already then identified, you know, the physician leaders here who really will take that information and go. And I just see this as kind of a springboard to future success, and really want to share it with folks because I think it's a worthwhile journey. So with that, to kind of give you some specific examples of where we've seen some success, and hopefully that you all can kind of use and take and again, tweak for yourselves and see the similar success. We'd also like to hear some of your stories, but I'm going to turn it over to Susan and let her go through that.
So thank you so much, Dave, and really thank you for all the support you've provided the pharmacy and supply chain teams to be successful with all these cost savings initiatives. Today, I'm going to share how, with the support of administration, we as a team were really able to put this approach into action. So anytime you propose a utilization change with prescribers, you really get met with a certain level of emotion and apprehension. So most physicians' personal preferences drive their prescribing. Our approach really to these situations has always been to bring forward the best clinical evidence to support the proposal. And over time, most of our physicians have really become comfortable with this approach. But early on in the process, we really didn't propose many changes with our oncology division specifically. It wasn't an area we were able to avoid for long, however. Obviously, rising costs in oncology and innovative and new medications in that area really prompted us to take a harder look at the infusion center with the attempt to explore savings opportunities within that department specifically. So our oncology physicians here at Alton were used to directing care independently, and at times were reluctant to make changes in their practice. They were comfortable with their own practice, were apprehensive to move forward with really any project they didn't have firsthand experience with. So the pharmacy team really reviewed national guidelines for oncology treatment and supportive care. And additionally, we benchmarked costs to identify 2 projects to pursue in that area, which were kind of the initial projects. We've had obviously subsequent projects, but those are around dose rounding to vial size when appropriate, and chemotherapy-induced nausea and vomiting, and developing a pathway there. During initial discussions with the oncology physicians, there were concerns about how this might impact their patients. They really weren't willing to pursue the project at that point. But we were able to leverage a physician champion from a sister hospital just to share his personal experiences with both projects. And in combination with the evidence and the hospital administration support, we were able to gain enough support to at least pilot the project within a small patient subset. The pilot enabled the physicians to gain comfort with dose rounding and determine it really wasn't detrimental to patient care. And over time, it was expanded to include all patients. Processes were put in place to make the program more automatic. The Alton staff, pharmacists pretty much do the dosing now independently to the vial size rounding. And order sets and pathways were developed to drive to the approved nausea and vomiting protocol. So this enabled us to see year-over-year cost reductions in both overall chemotherapy costs and costs of the rounded therapies. And as well in nausea and vomiting prevention, we were able to sustain those costs year over year. And as you can see, like a lovely downward trend. So none of which would have been possible if we had just accepted that initial, no, we don't really feel like doing that from the physician. But not all projects lead to such sustained results over time. So the key really is to keep your eye on any change you make to make sure the outcome you were expecting is the outcome that actually comes to be. You need to ensure, first of all, that the project was fully implemented. So that is key. Most people assume, okay, we've got the implementation date in and it's moving forward, but without really going back and doing those checks, we all know that old habits die hard and things kind of slip back into areas that you don't want them to go. So if you have not fully implemented, you need to identify and remove any barrier to that implementation, and as well as ensuring the full compliance over time. So we use purchasing trends as a surrogate to monitor basic compliance, as well as monitoring savings. DRG and physician information were used to identify sources of non-compliance, so we could, target and immediately act on certain patient types or certain physicians that were potentially using medications not as we had intended. So the process within BJC for monitoring savings is we monitor for 12 months following the implementation of a savings plan, and then periodically thereafter. To illustrate the importance of periodic compliance monitoring, I'd like to talk to you a little bit about our experience with the antibiotic class covering methicillin-resistant Staph aureus infections. I'm going to call those MRSA agents for the remainder of this webinar. We specifically started looking at MRSA agents in complicated skin infections, and I don't think we've stopped since we started, probably. But using an antibiotic with MRSA coverage in addition to other antibiotics was a fairly common practice in these complicated skin infections. We'd seen costs associated with complicated skin infections rise over time, and newer agents were coming to market. In that time period, we became kind of interested in a specific product called ceftaroline that offered the potential for a single agent coverage for these infections, and as a bonus, it was available at a lower cost. So it was added to formulary, and the pharmacy staff was able to work with our infectious disease physicians to really identify where ceftaroline could be used, and we monitored use and savings. So as you can see, we were able to realize savings in the first 12 months, and things were going well. But like with so many other medications, the acquisition price of ceftaroline increased. At the same time the acquisition price was increasing, physicians had gained more comfort with the product and were using ceftaroline more often. The overall utilization expanded beyond the original patient population into other infection types. Without periodic review, we would not have identified the price increasing or the increases in utilization over time. So general conversations about appropriate use really weren't necessarily impacting overall utilization on the long term. We'd see, short-term gains, and then they'd go back to utilizing ceftaroline because we had made it somewhat easy for them. As well, I think there was probably a drug rep out and about promoting his product as well. So we needed to identify the types of patients where ceftaroline was being used and who was prescribing it, with the ultimate goal of stopping inappropriate usage and reining in drug costs. Not just for a cost standpoint, but obviously we had a stewardship focus as well. So we turned to the DRG and utilization data to identify prescribers and diagnose and once again engage our physician champions to have one-on-one conversations with physicians to ensure our patients receive really the most appropriate antibiotic therapy. We were able to avoid further cost erosion and once again decrease overall MRSA as well as ceftaroline costs. We still have more opportunity in this class, and we will continue to focus on periodic checks to ensure compliance with all of our initiatives. I'd like to turn it over now to Kathy Chase to talk more about how utilization of data can drive change.
Thanks, Susan. Today I'm going to talk about really how to use benchmarks, looking at drug cost analysis as well as outcome analysis, and then using that information to identify savings opportunities. So let's start with benchmarking. Today, many hospitals have access to a broad range of benchmarks. Several of these have strengths and weaknesses, and it's important to understand each. Internal benchmarks are generally have the greatest data integrity. It may be your own data that you use to compare year-over-year information or physician practices within your hospital. But if you're part of a health system, it may also extend to comparing hospitals against one another. However, this always assumes that you have the best practices in place, which may or may not be the case. Comparison to other hospitals will give you deeper insights. I often recommend that hospitals start with a broad comparator group and then narrow their focus as they start to understand where they want to spend their time. For example, begin with hospitals that are similar in size and acuity to you. And then as you identify your area of focus, say cardiology, then you could layer in cardiology services into looking at that information. If you try to select hospitals that are exactly like you with the same exact services that you have, you're going to have a really small end to look at, and that may not give you the deep insights you want. Going back to that cardiology example, if I tried to then compare myself, make sure I had not only, 24-hour cath labs and cardiovascular surgery and things like that, but I also picked bone marrow transplants and burn units and a level 3 NICU, I may just get a lot of, lower my end and get a lot of hospitals that just provide a lot of noise into my information. So trying to focus on just where you're going for a specific initiative is key in selecting your benchmarks. When you start to look at drug cost analysis, and this would be true with any cost analysis, any supply analysis that you do, but for the sake of discussion, we'll use drug cost analysis. It's important to understand your data. So with your drug data, your purchase data, understand whether you're looking at your acquisition cost or an estimated cost or a patient charge. Just understanding that is going to be key. Then you might ask additional questions, such as the class of trade. Is it a GPO cost? Is it a 340B cost? Or even a wholesaler acquisition or WAC cost? Because each makes a difference. Does it include rebates or direct purchases? Or is it just purchases from your distributor or wholesaler? So knowing whether you have all the data and what's really kind of foundational there makes it more understandable. There are a lot of nuances in the data, and people will always try to say that the data is not valid. So just understanding those nuances can be key, particularly when you're looking at benchmarks. Then you need to think about, how am I going to volume adjust this? And lots of hospitals have their own standards and want to do it different ways. But if you're looking across large benchmarks, again, you want to use something that has is an industry standard. So something where you're looking at an adjustment factor is often key to take into account those outpatients as well as your inpatients. So you might look at adjusted patient days, adjusted admissions, adjusted discharges, and certainly acuity-based. So looking at maybe CMI adjusted discharges can give you some good insights or comparisons. And then finally, what are your data sources? Is it just a single source like your distributor or wholesaler, or are you pulling information from your hospital information system? And then knowing the nuances of that data is good. Often, not only is knowing the cost key, but understanding the outcomes can be equally as important. And that can be really powerful when you're looking at benchmarks. Now, many times we'll use a surrogate for data points for outcomes. For example, length of stay, defined daily dose, days of therapy are great surrogates to look at how well a patient has done, particularly on a specific drug regimen. For example, you might look at 2 drug regimens for a disease, let's say pneumonia, and you may actually find that using length of stay, one regimen has a shorter length of stay than the other. And that may not be intuitive. You may have 2 regimens, one's more expensive than the other, but if the length of stay is shorter, that can be key. And we often know that many vendors will promote their products, a drug or a supply, as superior because it shortens the length of stay. So being able to validate that can be important. So where should you look for those savings opportunities? Well, as you look at your data, oftentimes starting at the purchase data can be really helpful. Knowing what your cost drivers are, I like to look at, what are my top cost drivers, maybe my top 50 drivers. What's trending up? Susan talked about looking at trends continually because suddenly prices can go up or usage patterns can change. So see what's trending up. And then how do you compare to other hospitals? What's above the benchmark? If you hit that trifecta of top spend, trending up, and above the benchmark, those are key things that you might want to make an initiative. The next part of that is determining how do you affect change. And that's really digging into that utilization data. Who are the prescribers? And then how does that compare against other hospitals for treatment of that disease? So understanding both the cost variances and the length of stay variances within the DRG can really be key in trying to uncover different types of savings. So as you go down your data journey, it's really important that you invest in having an infrastructure for that data, because data can create that competition. It can actually be used to celebrate, to drive the change, but it can be really overwhelming. So trying to fine-tune what you're looking at is important to make it actionable. If you want to focus on the pharmacy, you can impact the length of stay to look at whether drug costs are providing overall value. And tracking that data on a continual basis is really critical to being able to sustain those savings. So I'm going to turn it over to Dave to kind of summarize what the experience has been here at Alton.
Okay, thanks again, Kathy. I think basically to kind of recap our journey, and I think some of the key points really gets back to optimizing the relationships that you already have. I mean, I think most of us know who on the medical staff are kind of the torchbearers and have been there in the past, are more innovative, really ready to kind of take on, I think, that additional responsibility and leadership within the organization. And then also, I think if you already know those folks from your pharmacy relationships, you may want to also reach out to your senior leaders in the organization, because sometimes they see that position, in a different setting. So as an example, that, Susan kind of went over with the medical oncology and sort of the assistance that we got from an outside source, which was really from one of our sister hospitals, and we knew that the medical oncologist here, even though being somewhat resistant to change, had a very respected relationship with one of the other medical oncologists across the system, and we were able to tap onto him and help us. And so I think, just understanding those relationships is key. Leveraging your current infrastructure, whatever that might be, so you're not, necessarily recreating extra time for everybody to attend meetings, et cetera. So use your P&T locally. Bring those system P&T opportunities back, and let's vet those and talk about those and how they fit at the local level. Your department chairs certainly can be helpful, and really they understand kind of the nuances that you may be facing in some of these opportunities that are identified. Utilizing the data is key. Obviously, what Kathy said, there's going to be nuances to the data. Understand them. Know that, don't just discount sometimes, the data, but really use it as sort of a guiding light to where you want to end up. It may, it's not a reflection on you per se if there's identifying some significant difference in cost for whatever denominator you want to use. It's really identifying an opportunity and an ability for you to ask questions around that data. Try things, it's kind of like as they always say, if you don't first succeed, try again, because persistence, I think, pays off. And I would just encourage that. And then also making sure you're tracking and measuring what you're doing so that at the end of the day, you know that you're making a difference. And if you're not making a difference, take a step back and let's see what else we can do. If you are making a difference and you've been successful, I think celebrating those results is key to this entire process. So that kind of wraps up, I think, what we wanted to present to everybody here. I'd certainly like to turn it back over well, before I do that though, I do want to recognize a couple of folks who have been keys to the success here at Alt Memorial, and Kelly Miller, who is with me here today, she's our pharmacy leader here locally, is involved in a lot of the system projects and certainly has done a lot of work around the success that we've had on this journey. And then Dr. Eric Stabell, who has been who is an infectious disease physician here on staff, but has also been chair of our local P&T in the past. He was a member of the system P&T when we were doing a lot of this work. Very engaged. Certainly knew his colleagues, and his colleagues respected him, and he was able to use that as a springboard to kind of bring other folks together to accomplish what we needed to do. So with that, I'm going to try to turn things back over to Beckers, and maybe we can open the line for some questions and discussion. Thanks.
Before we start in the questions, as they get them organized, I'll just ask one question of both Susan and Dave, and that is, you've talked a lot about having champions. The process is not immediate, so how do you keep them engaged along the way?
Dave,
I think the key is picking the right folks. From past experience, for the most part, who is engaged and who are sort of your leaders within the medical staff. And then really, explaining sort of the why, what we're asking for you to do and why we're asking for you to do that, then they can certainly carry out that message. And then, as we mentioned, monitoring your success really that's just having a touch point with those executive sponsors, champions periodically to say, we're making a difference or we're not. And so I think just by periodically checking in, bringing them to a variety of avenues where they can interface with their colleagues, I think goes a long way to keeping them engaged. But picking the right folks from the get-go helps, that's for sure.
I think just to add, we've had some champions that aren't necessarily the leaders of the organization or the department, but they had such a passion around the topic involved that they were able to, translate their passion to others and really get others engaged in the project and stay engaged. So, really finding those people that are passionate about the project, I think helps as well.
That's a great point, because I think in the past where we presented, the results of some of these projects, initiatives that we presented to our general medical staff, and I've had, some of the physicians come up to me afterwards and say, how can I help? And so, you want to latch onto that pretty quickly, and you can usually line them up with something where they can help and where they can certainly spend their time with their colleagues to make a difference at the end of the day and the outcomes of our patients. I think that's what everybody's in this for, is to improve overall patient care or patient outcomes and the experience.
Thanks, Megan. I think you were going to take the questions from here.
Excellent. Thank you, Kathy, Dave, and Susan, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. All right, so the first question is, you noted that it was key to leverage relationships with your physicians. What are some key ways you were able to engage the physicians in the process, and were there any surprises?
So again, I think that goes back to identifying your champions, and Kelly is in the room, and she's the one that leveraged physicians, pretty much on a daily basis and continues to do so. So I'll let her kind of tell you, what avenues she took.
My primary focus with physicians was to meet them where they were at. So I would attend their medical staff meetings for specific groups. So if I had an initiative that needed to be accomplished through the emergency department primarily, and that one, a big focus for them is antibiotic therapy. Most antibiotics are started in the ED for admitted patients, and it has been very helpful for me to attend their emergency department meetings, speak with the medical director and the providers in the ED that attend those meetings, and tell them statistically kind of where they're at, what's the data, what's their usage of, let's say, antibiotics or specific antibiotics, how do they compare to other hospitals in our health system, and what's their spend looking like, and where do I see indications for use and areas of opportunity for change. So meeting them where they're at with data I found to be very helpful. And regarding the oncology piece, I did a similar approach. I attended, or I'm already a member of the cancer committee, so attending that on a regular basis gave me the forum to speak to them, show them data, show what differences could be made in our spend if they would do something as simple as do dose rounding to the nearest vial size within certain parameters, and showing them data to get their buy-in for the percentages that we were rounding to. So we round to 5% for chemotherapy and 10% for biotherapy. And they at first were a little apprehensive about that and wanted to discuss curative treatment versus palliative treatment and look at the differences in those, rather than focusing on the fact that these were very minimal changes in the total doses. And after multiple presentations and really listening to their concerns, but showing them data, they were agreeable then to looking at, as Susan mentioned prior, a trial sample of patients where we could try this in to make sure that there was no bad outcomes and that everything looked good in those patients. And then we moved it forward to all of our dosing that we do in the oncology center.
Great, that's really interesting, thank you. One audience member wants to know, you mentioned that you track purchases to validate success and ensure compliance with initiatives. Do you also validate by reviewing actual patient orders, as purchases may vary due to errors, inappropriate ordering, and overstocking due to drug shortages?
So we do keep track of utilization as well as purchasing. So purchasing is kind of our radar, hey, let's go and investigate. But we always follow up with, you know, what patients are getting this, what physicians are ordering this, and if there is a mismatch, which, you know, Kelly's pretty good about knowing what's on her shelf here, but there is a mismatch, you know, that's corrected from an inventory standpoint immediately. But thank you.
Great, thank you for clarifying that. Another question, for year-over-year savings calculations, do you adjust for drug price inflation?
We do not. Inflation is built in. It's cost off the previous year run rate.
Okay, thank you. Can you share some of the methods you use? Sorry, go ahead.
Sorry, Megan. We do adjust for volume differences. So if your hospital volume is up 15%, we do make that adjustment, but not for inflation per se. Sorry.
Okay, no, thank you very much. Another audience member wants to know, can you share some of the methods you use to track and measure your data? Was it software-based?
So from a standpoint of tracking the data, we've been utilizing a proprietary tool that Cardinal has to track both the purchase and the utilization data over time. And then we actually establish baselines every year for the initiatives that we're going to look at, or through the year. If we pick up something in the middle of the year, we'll establish a baseline there and then measure the savings against the baseline. So if we feel that there's an initiative that we're going to start on today, and a year from now we feel like there's still dollars to be saved, we're going to actually reset those baselines. So we're continually challenging ourselves to drive additional savings out of the initiative.
Okay, thank you. We've received a ton of great questions. The next one is, what type of quality and outcomes measures have you implemented to assure your changes don't have a negative impact on patient care? This audience member is a chair of a P&T committee, and they always demonstrated that patient care was never compromised when they made utilization or auto sub changes.
So any change we make, obviously we try to keep that focus on monitoring, and we do have a system level quality group that tracks those types of alerts or notifications of any quality issues that we might have or errors that might subsequently come from it. But I think, like I'm sure oncology, I mentioned we were kind of leery that we would have some kind of outcomes impact. So we do keep a keen eye on, are we seeing any differences? Are we having more nausea and vomiting come out of there? And really those pilot processes kind of ensure we're not causing any kind of harm over time. I don't know, Kelly, if you have anything further that you're doing, but anytime we have a change, there is a keen eye looking to see, have we inadvertently caused something downstream?
Right. We have a safety event management system where all adverse reactions and patient outcomes, if they were other than is expected, should be tracked. So of course it is voluntary, so you're relying on the healthcare providers to enter those issues into the safety event management system, but we do track those routinely and ask questions. So in addition to looking at everything that was reported, we do a lot of asking the nurses and the caregivers if they have seen any trends, if they've seen anything different since we changed the process. as well as keeping in touch with the providers. We want to make sure that the physicians are not seeing something that they haven't told us about. But honestly, the physicians are pretty quick to tell you if they see anything happen when you make a change. So we haven't had any issues with that.
You know, just to kind of tag off of that, those responses, I think I mentioned earlier, reducing the total cost of care. And sometimes, you know, we want to kind of hone in on the pharmacy budget and are we reducing the pharmaceutical spend, I guess, so to speak. But that doesn't sometimes tell the real story. And sometimes the real story is more difficult to really define or really get an answer. If you're looking at length of stay, you know, we may track that according to some changes that we've made, but there's so many variables that can impact length of stay that, you know, you can't definitely say that because you change drug X to drug Y, that is the total, you know, difference in the reduction. I think you do the best you can. I would encourage you to maybe engage your finance group because, you know, they have tools that they can certainly pull in all aspects of utilization on certain hospital stays based on this, whatever, whether it's heart failure or heart attack, pneumonias, sort of you name it. And at least that gives you some idea if you're making an impact one way or the other. The other thing that we're learning, actually, and paying more attention to, particularly as patient care moves from the inpatient environment to a more ambulatory setting. Example, the outpatient infusion center. You know, you may see, obviously, improved outcome for a patient with a drug at a higher cost. And so, you know, really looking at and digging into that is sort of a new journey for us. And I think we're actually trying to look at that at the system level and understand that where it makes sense, where we actually see an increased pharmaceutical spend, so we're seeing an improved outcome for the patient. So just to note that.
Excellent. Thank you all for your insight there. And how do you handle difficult physicians who do not want to go along with initiatives?
Everybody's looking at me. We traditionally, you know, when we have those issues, obviously, for the pharmacy leaders, you know, I think push it to the next level up, and your executive leadership and the issues you're having, and I think that can help. You know, in this case, some cases I'm there, or you know, our other senior leaders are there to help and really have some, you know, crucial discussions with those particular positions. And I think sometimes it really is, you know, they don't understand the why. And I think that if you can explain that, and or at least get somebody who can help explain that, it goes a long way. You're not going to solve all cases, but I think in them too, what we've done here at least is if we can't get to it that way, then you start to engage the department chair. He or she may have some discussions around the same thing. We do monitor through the medical executive committee, you know, certain aspects of care for each member of our medical staff. And so, you know, these positions could end up on a focused review, and we monitor their change or not. And so I think that bringing it up through the physician leadership, ultimately, at the end of the day, almost always makes a difference.
Excellent, thank you. Another audience member would like you all to elaborate on your system P&T structure, voting rates by facility.
So I can take that. So we're a 15 hospital system, I think, where we're heading right now. So we have a representative from every system facility represented, with every facility getting a single vote. We follow straight majority rules in terms of voting. So, you know, really, if we're a split system, the majority does get the vote and carry. At the system level, there's a system formulary. Each facility is able to further restrict at the facility level from that formulary. But if an agent or a protocol is developed at the system level, or is denied at the system level, or there's some restriction at the system level, you can't go more broad than that system formulary. So we are set up with an academic center chair as well as a community center chair to try to bring balance to some of the decisions that might not impact all facility types, because we are such a diverse group. But one vote per facility.
And all of the voting members are physicians, is that correct?
Correct.
Yeah, I think the pharmacy leader has influence, but at the end of the day, it's actually the chair of the local P&T who has the voting authority at each institution. And, you know, I won't say that was a 5-minute discussion. I think it took a long time for everybody to kind of get there, but I think it's worked. And I think as people have kind of understood what we're trying to accomplish, and they get to know the folks that they're working with over time, that builds trust. And ultimately, at the end of the day, everybody pretty much is on the same page. Now, as Susan said, we're a very diverse system. I mean, we have, obviously, Barnes-Jewish Hospital, St. Louis Children's as our academic center flagship hospitals. They're a whole lot different than, obviously, our critical access hospitals down in Farmington and Sutherland, southern Missouri. So different needs, different medical staffs, and that's kind of why we have where the system decisions are made, you know, can be more restricted, but you can't broaden them. And then we're trying to do a better job of assisting some of our, especially our community hospitals, where they struggle sometimes. As I think part of the question was before, what do you do with difficult physicians? You know, sometimes we can bring in a clinical pharmacist expert from our academic center or one of our other community hospitals who's had success and help, so to speak. And we're trying to do a better job with that. Doesn't always work, but it's another tool.
Great, thank you all for your input there. Looks like we have time for one more question, and this one is for you, Dave. You mentioned impacting cost of care. With clinical opportunities that impact total cost of care but require additional pharmacy spend to achieve these total savings, how do you reconcile that within the pharmacy budget silo?
Well, I think, one, we have to do more analysis around that, obviously, because I said it's kind of sometimes difficult to validate. But at the end of the day, I think if you can make the case, then we would accommodate the pharmacy budget in total for that. So, and each hospital is going to be a little different because you have different service lines. You know, so if there's one particular drug, let's say, that's impacting a pharmacy budget one place or another, and it obviously has been approved by the System Pharmacy and Therapeutics Committee, first and foremost, then that's more of a local call, so to speak. And at the end of the day, it's me who's up in front of our system finance folks who are making the case that, you know, we need X number of extra dollars in our budget to accommodate this particular pharmaceutical spend in the oncology center, let's say, because we have something here we believe works, improves outcomes, and at the end of the day is the best choice for our patient.
And that is all the time we have for today. I want to thank Kathy, Susan, and Dave for their excellent presentation, and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.